بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the series of abdominal imaging, and we have finished with the gastrointestinal tract imaging, considering esophageal lesions, gastric lesions, small and large bowel lesions. Then we are now handling the solid organs. We'll talk first about the imaging of the liver. Then we'll have a second talk about the biliary imaging, then pancreatic imaging, then splenic pathology, and finally we'll have a talk about the peritoneum, the peritoneal and the mesenteric pathology. For this topic, we will handle those lesions that are specific for the liver in particular, and we first try to identify the current imaging modalities, including ultrasound, CT, and MRI. And to start with, I would like to draw your attention about the most likely indications for the CT scan of the abdomen, in particular for the liver. And as you all know, that one of the major indications is to assess an equivocal imaging finding. And the usual scenario is that a patient had a previous abdominal ultrasound, and the report came that there is something, and we would like to verify this something by another investigation, which is in most of the cases will be the CT scan. Then if we are sure about the presence of a hepatic neoplasm, then we would like to have the CT scan in order to assess accurately the extent of the lesion and to see the related lymph nodes and possible extension into the peritoneum, for example, or other distant metastases in the abdomen and pelvis. In the metastatic workup of primary malignancies, like any tumor outside the abdomen, breast carcinoma, osteosarcoma, for example, any of these lesions, we may have CT scan to assess the liver for the presence, or to assess the abdomen in general for the presence of metastatic lesions. Also, the diagnosis of diffuse hepatic disease can be performed by the a combination of ultrasound, CT, and MRI whenever relevant, as I will explain to you. Then the biliary problems will be discussed in a separate lecture. The vascular lesions, you know that CT now, especially the multi-detector CT, is one of the major tools in assessment of vascular pathology. And the assessment of post-traumatic complications has been explained in the lecture of abdominal trauma. Then we, in order to have a CT scan of the abdomen, we may need some preparation of the bowel by administrating oral gastrographine, and we may not need this bowel preparation. Then we will have the scanogram, which should be in the frontal view, and then you identify the area to be scanned from the level of the diaphragm down to the level of the pubic symphysis. And we usually scan the abdomen every 10 millimeter scan intervals. And as you all know, we have two types of examination of the abdomen. The first one is the abdominal scan, which is conducted from the level of the diaphragm to the level of the iliac crest, whenever the pathology is confined to the liver, the spleen, or the pancreas. Then the other exam, which is CT of the body, will include also the pelvis in cases the indications are not or the lesion is not reliably localized in a certain area, like diffuse abdominal pain, searching for lymphadenopathy, and searching for abdominal metastatic deposits. Then we usually need to inject the patient with intravenous contrast, and these are some of the types of contrast media available in the market. Then we started the examination, and we have sections too. In the sections you can see the liver on the right side, the spleen on the left side, and this is the stomach, which is full with the orally administered gastrografin. Here is the aorta and the IVC. I hope you remember the lecture of abdominal CT and MRI anatomy. Then we use, as I have said before, to have pre-contrast scans for the liver. Then we inject the contrast medium. And you remember that in the previous days when we started the examination after injection of contrast medium, we have some mistakes, missing some lesions, like in this case. And you see this is the post-contrast scan, and this is the non-contrast scan, and in the non-contrast scan you can see a focal lesion which is not seen in after injection of contrast medium. And this occurs whenever the lesion and the liver enhances to the same degree. Sometimes in some lesions the lesion takes the contrast media as similar as to the liver parenchyma. Then if you started the examination with contrast injection and you didn't have the pre-contrast scan, and you have the chance to miss one or two or some of the focal lesions, which are in many cases usually seen by ultrasound, of course, because of the different physical principle of the ultrasound and the CT scan. Then we performed this technique for some time, a pre-contrast scan and the post-contrast scan. You see the liver is enlarged, and you may identify some of the focal lesions inside the liver. But whenever the multi-detector CTs are available in the market, we are able to have this triphasic study, and we are able to scan the liver in the arterial phase when the contrast media is concentrated in the artery. Because you know that most of the hepatic pathology is supplied by the hepatic artery, while the normal liver parenchyma is supplied by the portal vein. Then in order to see the lesions in the liver accurately, you should scan the liver while the contrast media is in the artery. And you can know this by identification of the aorta, which is very bright, as similar as to the spine adjacent to it. Then in this arterial phase you can see too many focal hepatic lesions which are not seen in the pre-contrast scan, and also in the scan obtained after injection of contrast medium. Then this examination, which was known as the single phase contrast enhanced CT scan, was performed by obtaining a pre-contrast scan for the liver. Then we inject the contrast media intravenously, and we scan the liver once more. And if you look here, and you cannot see, you see that the liver is cirrhotic, the spleen is enlarged, and there are some ascites. And here you can see after contrast injection you cannot detect any focal lesion. But in the arterial phase of the same case, and you can see an enhancing focal lesion here, which represents a hepatocellular carcinoma. Then we came to a conclusion, or agreement that we should scan the liver whenever suspecting certain pathology as follows. First, we should have a non-contrast study. Then we inject the contrast media and we scan the liver in the arterial phase, while the contrast media is concentrated in the arteries. Then we scan the liver in the portal phase, and then we wait for 2 minutes and scan the liver once more, which is known as the delayed phase. Actually, you know that contrast media will reach the hepatic artery about 25 seconds from the start of injection of contrast media, and it will reach the portal vein about 55 seconds, and then you wait for some time and you have this. Then this study is known as the triphasic study, because you scan the liver in 3 phases after contrast injection: arterial phase, portal phase, and the delayed phase. Then this is an example of a triphasic study. The liver is cirrhotic and the spleen is enlarged. This is the pre-contrast scan, and you cannot see focal lesions in the liver. And in the arterial phase, you can see this enhancing focal lesion in the right hepatic lobe. And in the portal phase, you got some wash out of contrast from the lesion. And in the delayed phase, you can see that the contrast medium has been washed totally from the lesion, while the liver is still containing the contrast media. Then in some cases you have the chance to see the lesion better in the delayed phase. In some cases, not in all cases, but the lesion is usually well demonstrated in the arterial phase, particularly if it is hypervascular. Then these are very old technique used for assessment of the hepatic pathology in the era before the development or the introduction of multi-detector CT to the clinical practice. This is known as CT hepatic angiography. We used to introduce a catheter in the celiac artery and selectively into the hepatic artery. Then we transfer the patient to the CT room and we inject contrast media to have this arterial phase. And you see the marked enhancement of the lesions. And also you can appreciate that the aorta does not contain contrast material because the catheter is pushed selectively into the hepatic artery. Then this technique is known as CT arterial portography. After finishing this phase, you wait for a while. After the contrast circulates from the arterial to the venous side, then you scan the liver once more, and you see the liver is taking contrast media while the lesions, especially if they are hypovascular, are not taking contrast media. Then you have the chance to see better the hypovascular lesions in this phase. Of course, these two techniques are now obsolete after the introduction of the multi-detector CT. I will remind you by the segmental anatomy of the liver, and you know that the liver is divided into two lobes by a line passing from the IVC to the gallbladder. Then this is the left lobe and this is the right lobe. The left lobe is further divided into two segments by the fissure of the ligamentum teres into lateral segment and medial segment, while the right lobe is divided by a horizontal line from the IVC to the chest wall into an anterior segment and a posterior segment. And the surgical anatomy will consider that all these segments will divide into further two subsegments, one segment above and one segment below. I have explained this in details in the lecture of the anatomy of the liver, and I have said that in order to know whether you are in the segments that are above or the segments that are below, there is a reference. The splenic vein and the pancreatic tail are the reference for the lower sections, and the lower sections go in serial, and this is segment 3 and this is 4 and this is 5 and this is 6. And you remember that the part of the liver between the portal vein and the IVC will represent segment number 1. Then if you look here and you can see there is no splenic vein, there is no pancreatic tail, but the IVC is in the 8th fossa in the liver, then you know you are above. And in the above segments, and the above segments are not in serial, they correspond to segment 2, 4, 8, and finally 7. Then if you want to know the exact position of this lesion, it is in segment 2, and this lesion will be in segment 8, and this lesion will be in segment 7. Then if you want to revise the anatomy once more, you can go to the lecture of the hepatic anatomy by CT and MRI. Then we're discussing the focal hepatic lesions, and you know that the liver should be homogeneous. with no focal lesions, and its density is almost similar to that of the spleen. But if you look here and you can see a focal lesion in the liver, and this is what we call cystic focal lesion containing fluid, and this is another focal lesion which is not cystic, and we call this solid focal lesion in the liver. Then in order to appreciate the hepatic pathology, especially the focal hepatic lesions, we should discriminate between cystic and the solid hepatic focal lesions. Then, considering the diffuse hepatic diseases I will explain at the end of this lecture, they will include the fatty infiltration, liver cirrhosis, storage disease, and the diffuse malignancies. As I have said, that the density of the liver is almost similar to that of the spleen. If you have a scan and you see the liver is relatively black compared to the density of the spleen, then you know that this is fatty liver. And if you look here and you see the liver is shrunken with lobulated outline, and you see ascites, and the spleen is usually enlarged, then this is cirrhosis. But in patients who are not injected with contrast media, if you see that the liver is more dense compared to the spleen, then you know that this is a storage disease, and you may diagnose hemochromatosis or hemosidrosis in some conditions. Then we came to the assessment of focal hepatic pathology, and as I have said, we should discriminate between two major entities. The first one is what we call cystic focal hepatic lesion, which is containing fluid-like density, and solid focal hepatic lesions, which contain soft tissue material. Then sometimes you are faced with the lesion that is partly cystic and partly solid. And this mixed lesion in radiology practice is considered totally solid. And if you see a cystic lesion containing solid component, consider it totally solid, because this will help you in the differential diagnosis. And you can explain, of course, the presence of cystic changes within a solid lesion by the development of central necrosis and the breaking down. Then, if you see a cystic lesion in the liver, what are the possibilities? And if you see a solid lesion in the liver, what are the possibilities? Actually, we have 4 cystic lesions, or 4 possibilities for cystic lesion and 4 possibilities for solid lesions. The 4 possibilities are the simple hepatic cyst, the abscess, the hydatid cyst, and the hemangioma. And sometimes you feel that the hemangioma is not actually a cystic lesion, but it will appear on CT and MRI as if being cystic. Then it is included in this category based on its appearance on images. Actually, the simple hepatic cyst is easily diagnosed in the liver by all imaging modalities, ultrasound, CT, and MRI. In ultrasound, you see a hypoechoic lesion with posterior acoustic enhancement, which is typical for any cystic lesion anywhere in the body. And in the liver, is in the CT scan, you see a fluid containing cystic lesion in the dome of the liver, which is diagnostic of a simple hepatic cyst. Actually, for the diagnosis of a simple cyst anywhere in the body, in the liver, in the kidney, in the brain, in the muscle, in the ovary, anywhere in the body, there should be 7 criteria, and 3 positive and 4 negative criteria. The 3 positive criteria are the sharp, defined, well-defined margin, paper thin wall, clear water or fluid contents. Then the negative findings should be no septation, no calcification, no enhancement, and no mural nodules. Then if there is a lesion that can fulfill these criteria, you consider it simple benign cyst. And simple benign cyst may be solitary and may be multiple in cases of polycystic disease. And you see too many focal cystic lesions in the liver of variable sizes, as you can see. Then we agree about the criteria of a simple cyst, which is a congenital lesion and is usually detected late in the life because it is asymptomatic in most of the cases, and the complication will include the two well-known complications of any cyst that include rupture or internal hemorrhage. And this is the surgical specimen showing the criteria of a simple cyst with paper thin wall and fluid content, as I have said. And polycystic disease will be explained too many times, especially when we are talking about the kidneys, and you can see too many fluid containing cystic lesions in the liver as well as in the kidneys. And this is the appearance of a simple cyst by CT and by MRI T1 and T2. In the T1 weighted image, the cyst will show low signal fluid content, low signal in the T1 and high signal in the T2, and there should not be any enhancement or mural nodules, as I have said. This is the polycystic disease by MRI, and you see too many variable sized low signal lesions in the T1 and high signal lesions in the T2, diagnostic of polycystic disease of the liver. Then we came to the second lesion in this group, which is the hepatic abscess. And in order to discriminate the hepatic abscess from the simple cyst, the abscess have an inflammatory margin, and this margin will enhance with contrast mean. And being an inflammation, there may be a halo of hypodensity representing edema of the surrounding liver parenchyma. And sometimes you can see also air loculi inside this inside the abscess. And if you see air loculi without any history of previous intervention, then you can be sure about the diagnosis of a hepatic abscess. And the abscess may be multiple, and you see the abscess, the major one, and some of the daughter abscesses around. All these abscesses showed marginal contrast enhancement, as you can see in this particular case. Then sometimes the literature says that in order to discriminate between biogenic and amoebic abscess, you should look for the halo of edema around the abscess, and this will support the diagnosis of amoebic abscess. And now it is not a reliable sign for discrimination between amoebic and biogenic abscesses. And actually the position of the abscess, the location of the abscess, I mean, and the appearance of the edema, the enhancement, are not helpful criteria to discriminate between biogenic and amoebic abscesses. Then it's better to call this as an abscess, and we may have a sample from the contents in order to know whether it is amoebic or biogenic. And this is an example of a biogenic abscess with the surrounding halo of edema in the adjacent liver parenchyma. And you know that abscess like hemorrhage can be in the subcapsular area of the liver, of the kidney, of the spleen, for example, and this is an example of subcapsular abscess in the liver, and it shows the criteria of an abscess with thick enhancing margin. And the abscess in MRI will show similar criteria to the cyst, except that it will show an enhancing margin after injection of contrast. And this is T1 weighted image, the abscess is of low signal. T2 weighted image, sorry, the abscess is of bright signal. After contrast injection, you see marginal enhancement in the T1 post-contrast MR scan, as well as in the CT scan after injection of contrast media. And this is a classic appearance of an abscess in the dome of the liver, showing enhancing margin of regular thickness and a halo of abscess edema in the surrounding liver parenchyma. Then the third one in this category is the hemangioma, which is considered the most common benign hepatic tumor, and it represents about 20% of the hepatic tumors and is more common in females compared to males and is usually asymptomatic. Sometimes or many times a hemangioma can be multiple, and if the hemangioma reaches the size of 6 to 10 centimeter in diameter, it is known as giant hemangioma. And in order to separate hemangioma from the abscess, hemangioma will show marginal enhancement, but the enhancement will be nodular. And this is the classic appearance of hemangioma at angiography, and you see the enhancing nodules along the margin of the hemangioma. And this is the CT scan showing the cystic appearance of the hemangioma and the nodular marginal enhancement of the lesion. One of the supportive criteria for the diagnosis of hemangioma is the hemangioma, whenever it touches the hepatic contour, it does not disturb the hepatic contour. Any other lesion like metastasis or hepatocellular carcinoma, for example, if it is reaches the surface of the liver, it will result in disturbance of the hepatic contour. Then you should not assess the lesion whether it is cystic or solid unless you have a contrast study, whether this is a CT scan or MRI. And you are not allowed to assess the nature of the lesion in the pre-contrast scans, otherwise you will have many mistakes. Then in the post-contrast scanning, you see enhancing mural nodules, and this is the character of the hemangioma. One of the major characters of the hemangioma is that whenever you wait for some time, let us say 2 or 3 minutes, then you got diffusion of contrast filling the whole hemangioma, which is known as the iris sign. The iris of the eye, like the concentric centripetal diffusion of contrast media inside the hemangioma. Then in cases of large hemangiomas, you got enhancement along the periphery, which is nodular, and if you wait for some time, the hemangioma will start to fill. But in such cases of large hemangiomas, filling will not be complete because the center of the hemangioma is usually thrombosed and it will not fill with contrast medium. And all of you know that hemangioma by ultrasound will not appear as a cystic lesion. It will appear echogenic, as you can see here, because of the blood content. And in the CT scan, it will appear like cystic lesion with nodular peripheral marginal enhancement. And if you wait for some time, the hemangioma will fill with contrast media. And you should remember that 10% of the hemangiomas may show calcium. This is the sequence of events of hemangioma: nodular marginal enhancement, progressive filling in of the hemangioma, as you can see on serial imaging. In MRI, the hemangioma will show cystic appearance, low signal in the T1 and high signal in the T2. Then if you inject the contrast, it will show nodular marginal enhancement, and if you wait for some time, the hemangioma will fill with contrast media exactly similar to the CT scan. And these are two hemangiomas, one large and a smaller one. And after injection of contrast, you get nodular enhancement, and then the nodules will increase in the size. Then the contrast will diffuse to fill the hemangioma. The smaller hemangioma will fill with contrast more rapidly compared to the larger hemangioma. And this is hemangioma, and you see that this is T1 and before injection of contrast, the cystic lesion, low signal, and after injection of contrast, you got nodular marginal enhancement and progressive filling of the hemangioma with contrast media. And I have said that the hemangioma, which is in the range of 6 to 10 centimeter in size, is known as giant. And this giant hemangioma will not fill totally with contrast media because of the presence of thrombosis in its central part. This is also an example of a giant hemangioma occupying part of the left lobe of the liver as well as the right lobe. Then we came to the fourth one in this category, which is the hydatid cyst. And the hydatid cyst is a cyst in the liver with calcification. And this calcification can be central and more commonly seen in the periphery of the lesion. And the calcium by ultrasound will appear echogenic, as you can see, and the calcium by CT will appear hyperdense, as you can see. And in order not to mistake this as enhancement, look for the density of contrast media in the aorta and in the IVC. Of course, calcium is more dense than the contrast media. Then this is calcification, not enhancement. And if you see a cystic lesion with calcium inside or on the periphery, then you suspect the possibility of hydatid cyst. And this is another appearance which is also a common and a classic appearance of hydatid cyst. And you see a cystic lesion without calcification, and inside the cyst you have some floating shadows. And these floating shadows represent the endocyst and one of the pathognomonic criteria of hydatid disease. And if you see a cystic lesion in the liver with some floating shadows inside, you are sure that this is hydatid disease. And this is the most typical appearance of hydatid cyst anywhere in the body. You get a lesion which is large with multiple mural small cystic structures representing the daughter cysts. This classic appearance of hydatid cyst can be seen in the liver, can be seen in the kidney, and can be seen also in the brain. Then, if you see a lesion, a cystic lesion with marginal calcification, this is hydatid. If you see a cystic lesion with floating internal shadows, this is hydatid. And if you see a lesion with internal mural cystic lesions representing the daughter cyst, then this is hydatid. Also, one of the major criteria, if you see a cyst which is similar to a simple hepatic cyst, and you see another cyst in the lung, and you remember from the thoracic imaging that the only lesion containing water in the lung is the hydatid cyst. Then if you see a lesion in the lung and another lesion in the liver, you should diagnose that in the liver as hydatid cyst if it does not show any of the previously mentioned criteria of hydatid disease. And this is T2 weighted image of an MRI of hydatid cyst with classic big lesion and mural small daughter cyst along its margin. And this is the appearance, the operative appearance of the hydatid cyst. And as I have said, hydatid cyst can occur in the liver and can occur in the kidney as well as in the spleen. I will explain this in the specific issues. When I'm talking about the kidney, I will explain the hydatid disease in the kidney and also in the spleen. Then if hydatid cyst is dead, you got calcium everywhere in the cyst, and then you see marginal calcification and also calcium inside the cyst itself. Then we have 4 cystic lesions in the liver that are benign, and these are the simple cyst, the abscess, pyogenic and amoebic, the hemangioma, and the hydatid cyst. And I have explained to you how can you easily discriminate between these lesions. Then we have an exception for the rule, which is in the cystic lesion that can be malignant. And we have 2 possibilities here, the biliary cystadenoma or cystadenocarcinoma and the cystic metastatic deposits. The biliary cystadenoma or cystadenocarcinoma is a big cystic lesion in the liver with in many cases it has internal septations and may show mural nodules. One of the major diagnostic criteria of this lesion is the presence of dilated biliary radicals around this cyst. This is, in my opinion, the most reliable sign to diagnose this cystic lesion, particularly when it is unilocular. Then these are the criteria of biliary cystadenoma. It's an uncommon benign cystic neoplasm of the liver and occur predominantly in middle-aged patients, more common in women, may be unilocular or multilocular. The fluid of the cyst may simulate water or may be hemorrhagic. The cyst is usually large, ranging from 3 to 40 centimeters in diameter. Calcification may be seen in the septations or in the cyst wall, and the mural nodules and papillary projections may be seen in the lumen of the cyst, and this cystadenoma have the potential to be turned into cystadenocarcinoma. And if you look for this lesion and you see septations and you see calcium, then, as I have said, one of the major criteria is to identify some of the dilated biliary radicals related to the lesion. And this is a good example of unilocular biliary cystadenoma. And you see the dilated biliary radicals around the lesion in the contrast enhanced CT scan. And this is MRI or MRCP. And you see the lesion with dilated biliary radicals around. And this is biliary cystadenoma, large lesion with internal septations, and septations may enhance and may show calcium, as you can see in this particular case. Then sometimes you may misdiagnose this lesion as a hydatid disease because of the calcium, but the presence of dilated biliary radicals, the size of the lesion, the extent of internal septations are usually reliable diagnostic criteria. But it is usually written in the books that there are no reliable signs to discriminate between biliary cystadenoma and the cystadenocarcinoma. So the biliary cystadenoma, whenever it is diagnosed, it should be removed because of its potential to turn into a malignant lesion. In my opinion, if you see thick internal septations or together with papillary projections or mural nodules, these are the supportive or suggestive criteria for you to suspect the possibility of biliary cystadenocarcinoma rather than cystadenoma. Then cystic metastatic deposits are not usually diagnosed unless you know that there is a known primary malignancy. Whether this primary malignancy is seen in the scan, like this pancreatic head cancer, or known from the history. And you know, some of the tumors usually give cystic metastasis, particularly those of the pancreas and those coming from the ovary. Then in the colorectal cancer, you see this patient is known to have colonic cancer, and there are two lesions. One is solid and one is cystic. Then you should diagnose both as metastatic deposits, and you cannot say that this is metastasis and this is the simple cyst, for example, or an abscess. No, you should consider all lesions as metastatic deposits. Then we finished by the cystic lesions, and we mentioned the most common benign cystic lesions and the exception of the malignant conditions that may show cystic aplasia. Now we came to the solid lesions, and they are considered malignant with exceptions of solid lesions that are benign. The four common solid malignant lesions in the liver are the hepatocellular carcinoma, the cholangiocarcinoma, the lymphoma, and the metastatic deposits. Then we'll have this benign aspect of solid lesions, including the focal nodular hyperplasia and the hepatic adenoma. You know that the most common primary malignancy of the liver by far is hepatocellular carcinoma, and it has a great intimate relationship to the liver cirrhosis. and 80% of hepatocellular carcinomas occur in the cirrhotic liver. The serum alpha-fetoprotein and the ultrasound are usually used for screening a patient with cirrhosis, looking for the possibility of hepatocellular carcinoma. And you see the tumor is solid, and this is the appearance in ultrasound, and this is the appearance in the CT scan. And you remember that whenever hepatocellular carcinoma is suspected, then you should have the triphasic study of the liver, starting by non-enhanced scan, then the arterial phase, the portal phase, and the delayed phase. In the arterial phase, you look carefully for enhancing lesions, and they are highly suggestive of being hepatocellular carcinoma. As you can see in this particular example, the lesion is not seen in the pre-contrast and not seen in the portal phase. Then this is an MRI study which can be also performed on the basis of triphasic study. This is the T1 without contrast, and this is the arterial phase, the portal phase, and the delayed phase. And you may feel that there is something here, but in the arterial phase you got significant enhancement of the lesion, and then wash out of the contrast medium in the portal and the delayed phases. Then not every case with cirrhosis should have a hepatocellular carcinoma. And many times we examine the patients with triphasic study. They have cirrhotic liver and no focal parenchymal disease. And this is an example. The liver is cirrhotic in the pre-contrast study. In the arterial phase, you cannot identify any enhancing lesion. And so in the portal phase, you cannot see any lesion. Also, you appreciate the splenomegaly and the dilated portosystemic collaterals at the splenic hilum, denoting the presence of portal hypertension. But in the arterial phase, if you see this appearance and you got enhancement, whether nodular or focal or mass or patchy or diffuse, then you suspect or you should consider the possibility of hepatocellular carcinoma. And this is a multifocal disease. You see a big lesion here, and all these enhancing nodules belong to the tumor as well. Then this is the CT scan. In the arterial phase, you see heterogeneous enhancement of the lesion, which occupies most of the right hepatic lobe. And this is the portal phase, and the follow-up of this patient after 2 months showed invasion of the IVC by a tumor thrombus. And you remember this triphasic study where the lesion was better appreciated in the delayed phase, and this, as I have mentioned, is an exception seen only in some of the cases, especially if the tumor is relatively hypovascular. Then this is the hepatocellular carcinoma before contrast injection and in the arterial phase, and you can see the heterogeneous enhancement, and you can see also the central areas of breakdown. This is the full series: arterial phase, portal phase, delayed phase of hepatocellular carcinoma. And this is the arterial phase, portal phase, delayed phase by MRI, showing an enhancing hepatocellular carcinoma in the right hepatic lobe. And this is MRI T1 and T2 weighted image of a big hepatocellular carcinoma occupying most of the right hepatic lobe, showing intermediate signal in the T1 as well as in the T2 weighted image. And this is the arterial phase, the portal phase, and the delayed phase of the same case. Then you know there are 3 types of hepatocellular carcinoma: a single focus or multifocal or diffuse hepatocellular carcinoma. And this is an example of multifocal. You see 2 lesions in the liver, low signal in the T1 and high signal in the T2 weighted image. One of the well-known types of hepatocellular carcinoma is the fibrolamellar type, which represents about 1 to 9% of all hepatocellular carcinomas. And this tumor has no specific relation with cirrhosis, and also has no relation with the alpha-fetoprotein. This tumor is usually large and is usually containing a central scar, and this scar may show calcium. And because this appearance will be mistaken for the focal nodular hyperplasia, which is the benign lesion, I will show the difference in between both pathologies in a moment. And then look at this lesion, and you see a solid lesion in the liver, which is relatively cirrhotic, and you consider this is a hepatocellular carcinoma, whatever it is, a focal, fibrolamellar, or otherwise. Then fibrolamellar hepatocellular carcinoma is usually large, more than 12 centimeter in diameter, is heterogeneously enhancing like any hepatocellular carcinoma. It contains a hypodense central scar, and this scar may show calcification. Then this is a rule which we said is in this rule the literature says that if a focal lesion in the liver does not meet the criteria of a simple cyst or hemangioma, should be considered hepatocellular carcinoma in the cirrhotic liver until proved otherwise. In hepatocellular carcinoma, one of the ways of management is to do arterial embolization, and this is after embolization of a hepatocellular carcinoma with total accumulation of the lipidol, which is usually injected with the chemotherapeutic drug into the liver, and this should not be mistaken for any of the calcified lesions because of the history and the previous examinations. And if you see a solid lesion in the pediatric age group, and this is hepatoblastoma. Hepatoblastoma is the most common primary neoplasm in children, especially below the age of 5 years. And this is one of 3 main lesions presenting by abdominal masses in the pediatric age group, which are the hepatoblastoma, the nephroblastoma or Wilms tumor, and the neuroblastoma. This tumor has a good relationship to the alpha-fetoprotein and is usually a huge lesion affecting most of the liver parenchyma, and it may show parenchymal calcification. And you see this female child, 6 years old, with a big mass involving most of the liver parenchyma, leaving this area in the liver. And this is a 6 months old male, a child showing a huge mass in the left lobe of the liver, diagnostic of hepatoblastoma. And this is the female infant, 2 months old, with a huge mass infiltrating the left lobe and sagging from the inferior hepatic surface, showing foci of calcification. And this is the gross specimen of hepatoblastoma affecting the right hepatic lobe. Then we came to the cholangiocarcinoma, and you know, the ratio between hepatocellular carcinoma and the cholangiocarcinoma in the liver is about 10:1, meaning that it's not that common compared to hepatocellular carcinoma. The cholangiocarcinoma has no association with cirrhosis, and it has no specific CT or MRI appearances. But in my opinion, one of the most reliable diagnostic criteria for cholangiocarcinoma is the presence of a solid focal lesion in the liver surrounded by dilated biliary radicals, because this cholangiocarcinoma has arisen from one of the bile ducts, and this duct will be, of course, obstructed. Then the ducts draining into the obstructed duct will be dilated, as you can see. Then one of the reliable diagnostic criteria of cholangiocarcinoma is you can see an infiltrating lesion in the liver surrounded by dilated biliary radicals. Of course, you know that hepatocellular carcinoma is able to invade the bile ducts and obstruct the bile ducts, but the incidence of hepatocellular carcinoma to do this is far below the incidence of cholangiocarcinoma, which is almost 100% invading the bile duct and obstructing the bile duct. And you see a mass surrounded by dilated biliary radicals, and you expect the possibility of cholangiocarcinoma. And this is cholangiocarcinoma by MRI, T1 weighted image and T2 weighted image, and the arterial phase and portal phase. And the dilated biliary radicals are seen around the lesion, and you see the lesion which is heterogeneously enhanced. Of course, you may appreciate the lesion in the CT scan more better than in MRI. And the types of cholangiocarcinomas, this is the what is known as Hyler type or Klatskin type, a structure of the common hepatic ducts and the proximal part of the common bile duct. I will explain this in the biliary imaging lecture. Then we came to the third issue in this group, which is the lymphoma. And primary lymphoma of the liver is rare, while secondary is more common and is seen in immunosuppressed patients in most of the cases. But the lymphoma in the liver has no specific diagnostic criteria, either by ultrasound or by CT or by MRI. And in my opinion, the most reliable diagnostic criteria for lymphoma in the liver is to identify other lesions in the spleen, because you know that the most common solid lesion in the spleen is lymphoma. I will explain this in the splenic lecture. Then if you consider this lymphoma, then you consider that in the liver as lymphoma, and you consider lymph nodes also to be of lymphomatous nature. And this is a good example of lymphoma infiltrating the spleen and infiltrating the liver. And one may ask that if the patient is known to have a primary malignancy, is it possible to have metastasis in the spleen and the metastasis in the liver? Yes, it is possible, but you should know first that the patient had primary malignancy. If you don't know, then the diagnosis of lymphoma is good. And this is the case of multiple lesions, particularly in the spleen, in the liver, and in the kidneys. Then considering the lesion in the spleen, those will represent lymphoma, and those in the kidney will represent lymphoma as well. Then finally we came to the hepatic deposits, which is the fourth one in this category. And hepatic deposits are diagnosed by multiplicity and by the known history of primary malignancy. You know that the hepatocellular carcinoma can be multiple, the lymphoma can be multiple, metastasis can be multiple. But in order to separate those entities, you know that hepatocellular carcinoma has intimate relation to liver cirrhosis, but lymphoma and metastasis do not have this relation with cirrhosis. Then one of the suggested criteria of metastasis is to identify that the liver is not cirrhotic. This is the first issue. The second issue is to see multiple lesions, and if you know the primary malignancy, this will be of much more help. This is the case of pancreatic cancer, showing multiple focal hepatic lesions representing metastasis, and this is a prostatic carcinoma showing multiple focal hepatic lesions representing metastatic deposits. Calcium can occur in metastatic deposits, particularly those coming from mucinous adenocarcinoma of the colon, as you can see in this non-contrast study showing multiple calcified metastatic lesions in the liver. And there's a big problem to identify metastasis in fatty liver. And this, as I have said in the lecture of the anatomy, the role of MRI. MRI can clearly identify metastasis in fatty liver, but the CT has some difficulties to do this. Metastasis can be hypovascular. Then if you have the arterial phase, and you can see focal lesions which are not enhancing, this is the case of breast cancer. But if you wait for the portal phase, and you will see this classic appearance which is known as the target sign. And the target sign is one of the diagnostic criteria for metastatic deposits. If you see multiple ring-like enhancement, particularly if the outer ring is hypodense. Then deposits, if they are hypovascular, they will not be seen in the arterial phase, especially if they are small, and they may be seen better in the portal phase because they will not enhance and the liver parenchyma will enhance. Then you see the metastatic deposits as hypodensive foci on the background of enhanced liver parenchyma. As I have said, the target sign is one of the suggestive diagnostic criteria of metastatic deposits, particularly if the outer ring is non-enhancing, then you got an enhancing ring, and so on. And this is MRI T1 and T1 post contrast showing the metastatic deposits with the target sign. Metastasis will show low signal in the T1, high signal in the T2, and the heterogeneous post-contrast enhancement. And this is MRI T1 weighted image after contrast injection, and you see multiple focal lesions representing metastatic deposits. And this is the CT scan and MRI. As I have said, but in the fatty liver, it's difficult to identify metastasis because the liver is hypodense and metastases are usually hypodense. But in the MRI, the fat will show bright signal in the T1, while metastasis will show low signal in the T1, and you can appreciate metastasis in the T1 weighted image without the need to inject the contrast media. Then we have finished with the 4 lesions that are malignant, including the hepatocellular carcinoma, the cholangiocarcinoma, the lymphoma, and the metastatic deposits. And now we came to the benign aspect of the solid lesions, starting by the focal nodular hyperplasia. And you know that this lesion is not a neoplasm. It is just a proliferation of hepatocytes around an abnormal artery embedded in a fibrous scar. And this lesion is hypervascular. It enhances strongly in the arterial phase and contains a central scar. And so you may mistake this lesion for the fibrolamellar hepatocellular carcinoma, and I will show you the difference. The focal nodular hyperplasia represents the cut section of an orange with a central non-enhancing scar and the peripheral tumor tissue which is hypervascular. This lesion is rare and is usually asymptomatic. In 90% of the cases is found incidentally, and in 90% of the cases it is seen in this decades of age, and in 90% of the cases is a solitary lesion less than 5 centimeter in diameter. Remember, the fibrolamellar hepatocellular carcinoma is a large lesion, may reach 12 centimeter in diameter. And the fibrous scar will not enhance in the arterial phase, but it will enhance in the delayed phase, while the scar of the fibrolamellar hepatocellular carcinoma does not enhance. And this is an example of focal nodular hyperplasia with a central scar, and the scar has enhanced in the delayed phase. This is one of the helpful diagnostic criteria of focal nodular hyperplasia, while the scar in the fibrolamellar hepatocellular carcinoma does not enhance and usually show calcification. Then focal nodular hyperplasia by MRI will appear of intermediate signal in the T1 and T2 weighted images, and it will show enhancement, and the scar will show enhancement in the delayed phase. Then this is the difference between focal nodular hyperplasia and fibrolamellar hepatocellular carcinoma. The focal nodular hyperplasia do not show calcification or hemorrhage or necrosis, and in 90% of the cases the tumor size is less than 5 centimeter in diameter. But this lesion is usually large. It contains calcium in about 70% of the cases, and it may be associated with other malignant criteria like ascites and metastatic deposits in about 70% of the cases. The hepatic adenoma or hepatocellular adenoma is a benign lesion, and this benign lesion, if it show the classic criteria, it can be reached from the imaging, but if it does not show the classic criteria, you cannot suspect the possibility. As you know that this tumor has an intimate relation to females, especially those receiving oral contraceptive pills. This tumor is large in the subcapsular area of the right hepatic lobe in most of the cases, and it may reach about 10 centimeter in diameter, with particular finding is the presence of internal hemorrhage because of the hypervascularity. And if you see a lesion which is big in the right lobe of the liver containing hemorrhage in a female patient receiving contraceptive pills, then you may think of hepatic adenoma. And you can see that this is a solid lesion containing a focus of hemorrhage. It occupies most of the right hepatic lobe. And being a hypervascular lesion, you should be cautious whenever you are attempting guided biopsy from these lesions to confirm the diagnosis. And this is an example of a bleeding hepatic adenoma without being touched by needle biopsy. Being a vascular lesion, it may leak, it may bleed into the adjacent peritoneal cavity. Then we came to the focal hepatic diseases, and I have mentioned the fatty liver, the cirrhosis, the storage diseases, and the malignancies. You diagnose fatty liver by the fact that normally the liver is almost similar to the spleen in density. If the density of the liver is low compared to that of the spleen after injection of contrast, you consider fatty liver. If the liver is shrunken with lobulated outline, you consider cirrhosis. If the liver is dense than the spleen in the pre-contrast study, you consider storage disease. Then cirrhosis is an imaging diagnosis that can be achieved by ultrasound more better than CT and MRI. And the early stages of cirrhosis are easily appreciated by ultrasound, while CT can show the more advanced stages of cirrhosis. And it's usually said that there is shrunken liver, particularly affecting the right lobe, while the left lobe and the caudate lobe are abnormally enlarged, and there may be ascites, and the spleen is usually enlarged, and you got signs of portal hypertension in the form of dilated portosystemic collaterals around the spleen and in the region of the gastroesophageal junction. And the issue of portal hypertension will be explained in details in the lecture of splenic imaging. Then this is one of the measurements that can be used for assessment of the cirrhosis, and it's known as the caudate right lobe ratio. And you draw these vertical lines from the lateral hepatic contour and from the end of the right lobe and touching the edge of the caudate lobe. Then this is the caudate lobe and this is the right lobe, and you divide this distance by this distance. If the caudate lobe to the right lobe ratio is 0.6 or more, and you can assume cirrhosis, because this means that the caudate lobe is abnormally enlarged. Then portal vein diameter more than 1.3 centimeter may suggest also the appearance of cirrhosis. And this is cirrhotic liver, a small shrunken liver with hypertrophied caudate lobe and widening of the interlobar fissure, the lobulated outline, coarse parenchymal texture, and the spleen is enlarged, and you can see some fluid in the peritoneal cavity. Considering the issue of regeneration nodules, which are nodular lesions that show intermediate signal in the T1 and T2 weighted image, and they do not enhance with contrast media, identified particularly in the cirrhotic liver. And you may remember that I have said that MRI is considered a reliable technique to discriminate between cirrhotic regeneration nodules from the basal carcinoma, because regeneration nodules will appear low signal in T2 weighted image due to the hemosiderin content, and you see low signal in the T1 and low signal in the T2, while the basal carcinoma will show some brightness in the T2 weighted images. Then the issue of portal hypertension, as I have said, will be discussed in the splenic lecture, and you see here dilated portosystemic collaterals around the spleen, and also they can be seen at the gastroesophageal junction, representing portovenous collateral channels. And this is CT portal angiography. The liver is shrunken, the spleen is large, and you see esophageal varices at the gastroesophageal junction. The coronal reconstructed CT image showing dilated portosystemic collaterals and the splenic hilum. And this is huge esophageal varices seen by axial CT scan, at the lower end of the esophagus. You see the markedly dilated tortuous collateral venous channels. Then some of the findings of cirrhosis also include widening of the fissure, with the fissure for the ligamentum teres, the gallbladder and the small bowel wall thickening. Sometimes you see this, and of course the signs of portal hypertension in the form of dilated portosystemic collateral venous channels. Then one of the diffuse diseases in the liver is the fatty infiltration, and the causes are well known to all of you, including alcohol and obesity, diabetes, hepatitis, and some of the drugs, especially the chemotherapeutic drugs. Fatty infiltration may be diffuse, may be focal, may be multifocal, and the normal density of the liver is usually 8 Hounsfield unit greater than that of the spleen. But this difference cannot be usually appreciated on the CT scan, and you always see the liver is of similar density normally to that of the spleen. But in cases the liver is hypodense compared to the spleen, and this is fatty, and the fatty infiltration may be focal like this. And the most reliable diagnostic finding to diagnose these as focal fatty infiltration is that you can see the vessels crossing through the lesion undisturbed. And if you see the lesions crossing through the vessels crossing through the lesions undisturbed, then you know that this is fatty infiltration. And here is also an area of focal fatty infiltration and fatty infiltration of the right hepatic lobe, and you see vessels crossing through the fatty areas undisturbed. And on the opposite side, you may got fatty liver with a small area of focal fatty sparing, and this may represent a problem by ultrasound and sometimes by CT. But if you use the same criteria that vessels are seen crossing through this area undisturbed, and you know that this is not a pathology, but it is a normal hepatic tissue. And this is an area of focal fatty sparing in the caudate lobe. And in ultrasound, you know that fat is echogenic, and this is the CT scan, and you see the vessels. And by MRI also you can confirm the diagnosis if you have the in phase and out of phase imaging, as I have mentioned in the lecture of the anatomy. Then storage diseases, including iron overload, can be diagnosed by CT and more reliably by MRI. If you look to the liver in a study without injection of contrast, then you see increased density of the liver compared to that of the spleen. But you may ask, what happens if the spleen is also infiltrated or affected by iron overload? Then the role of CT cannot the CT will be unreliable in such conditions. In MRI, you know that iron is very dark in all bulk sequences, especially in the T2 weighted image and the gradient image, of course. And you see that the liver is very dark, and the darkness is judged by in comparison to the muscles, because the muscles are not usually affected by iron. Then if the liver and the spleen are affected and you want to know if this is normal or not, and you look for the muscles. And this is an example. The liver and the spleen are affected by iron overload, while the muscles are still of normal signal. And this is an example of iron overload in the liver, as you can see here. Then the issue of diffuse neoplastic disease, we have diffuse hepatocarcinoma, diffuse metastasis, and diffuse lymphoma. The diffuse type of hepatocarcinoma is usually seen in the cirrhotic liver, and in this cirrhotic liver you see too many nodules scattered throughout the liver parenchyma, and they will show enhancement in the arterial phase and wash out in the portal and the delayed phases. Then this is cirrhotic liver, which is diffusely infiltrated by hepatocarcinoma, and you see the splenomegaly and the signs of portal hypertension. Diffuse metastasis, for the diagnosis you need to know that the patient had a primary malignancy, and you see too many metastatic deposits affecting the entire liver parenchyma. And this patient with pancreatic non-functioning islet cell tumor showing multiple metastatic deposits affecting most of the liver parenchyma. And diffuse lymphoma can affect the liver and the spleen, as I have said. And you see the spleen is diffusely infiltrated by solid masses, and the masses also seen in the liver. Finally, we came to this problem, which is the problem of minute focal lesions. Whether these lesions are cysts or abscesses or metastatic deposits. Actually, this item, which is metastasis, is very important whenever the patient has a primary malignancy and you want to know whether these are metastases or otherwise. Then the helpful criteria, number one is the clinical history, and if you see a primary lesion in the scan, you may suspect a metastasis, and lesions present in the previous studies, and this is very important, and the help of other imaging modalities. Like in this case, you see multiple focal lesions, and then the T2 with the images they show very bright signal similar to water. Then you consider these as simple cystic lesions. In ultrasound, you know that the cysts will show some posterior acoustic enhancement, but in the CT scan, you cannot reliably judge these lesions as cysts or solid, but in ultrasound, you can say safely that these lesions are solid. Then this is an example of a male patient, 45 years old, and he has a known history of nephrectomy for a malignant lesion. Then he is presenting for follow-up, and he has multiple small focal hepatic lesions. Can you consider these as metastasis or just simple cysts or so? Then this is the help of the value, the value of the previous studies, and these lesions were present preoperatively and did not change in size over 6 months. Then you may consider them as benign lesions, and thank you very much. Alhamdulillah Rabbil Alamin.